Before I start, I want to make an apologize. You do not have my slides. For some reason they didn't reach here, but you are all going to get them within the next day or so, I was promised, by your email. So watch your email, you are going to have the slides. So right now, look at the images. M-mode echocardiography has practically only one dimension. And it's true that you see a two-dimensional picture, but one dimension is what we measure, and the dimension that we measure is depth. The other dimension of the picture is simply the speed of the paper or the speed of the screen, and therefore the other dimension is time. So what we have is depth against time. M-mode offers better time and image resolution. The sampling rate of a 2D image is about 30 times per second. The sampling rate of M-mode is 60 times higher. It's 1800 times per second. The images, therefore, as you can see, and the definition of endocardium is much better than what you can get by two-dimensional echo. The disadvantages are well known to you. This is a single dimension, as we said, depth only. The other dimension, remember, is time, right? It's not a geometric dimension. It can be non-perpendicular orientation, and therefore, if you do M-mode, always you use two-dimensional guidance. So you really know in what direction your beam is going. We are going to cover a few classical appearances of M-mode. Some of them are really history, but this is important to know, and in many cases also very helpful. And I just want to remind you that measuring against time, M-mode, kind of, is what you have when you record spectral Doppler. But in spectral Doppler, we don't have people like Dr. Wiggers that come and say, this is nothing. I mean, because it's something. All right. So, this is a normal mitral valve. It has a characteristic open. When it opens, the anterior mitral leaflet moves toward the septum. And then after it opens rapidly during the rapid ventricular filling, you see there is no gradient across the valve, and therefore the valve is floating back toward the closure position. And then with atrial kick, it's reopening to close at the end of the diastole. You see that the posterior leaflet has a characteristic motion. This is looks like M. The posterior leaflet looks like a W. The posterior leaflet is smaller, and therefore its excursion is smaller, and you have a characteristic appearance of the M-W appearance that indicates normal mitral valve without mitral stenosis. On the other hand, mitral stenosis looks totally different. Okay? What you have, first of all, you see that the echo images are thick because the leaflet is thickened. Okay? And then you see that since the two leaflets are fused, since the commissures are fused, the posterior leaflet has an abnormal diastolic anterior motion. You see, normally it's moving the other way. Here it's moving the same way. The two leaflets are moving in the same way. And also, because once the mitral valve is opened, there is gradient across the valve, and therefore it never floats back toward the closer position, and therefore you don't have this decline, right? And you have just a flat, what we call E to F slope. The E to F slope is flat, and this is all characteristic of mitral stenosis. This has very high sensitivity and specificity, and when a patient has something like that, we know that he does have significant mitral stenosis. Left atrial myxoma has a very characteristic echocardiogram. First of all, left atrial myxoma can give you mitral stenosis, because when the myxoma is moving toward the mitral orifice, it creates a gradient across the valve. And because it creates a gradient across the valve, look at the EF slope. It is really flat EF slope. It doesn't go backward. But you can see the myxoma. You can see this mass of echoes that is moving into the mitral orifice. And please note that very early in diastole, after the mitral valve opens, there is a lucid interval that you see here. What is this? This is the blood flowing across the valve. And when the blood flowing across the valve, finally it takes with it also the mass of echoes, and this is also moving at the mitral valve, at the mitral orifice. So initially, you see that this is very clean, only blood is flowing, and then a little bit later comes the myxoma itself. By the way, this patient has also tricuspid myxoma, so these are two myxomas. This is a condition known as the Carney syndrome, when you have more than one myxoma, right left atrial myxoma, and also other tumors. Another characteristic appearance is that of mitral valve prolapse. Pay attention to this. This appears, some of those will appear in the exam. There is M-mode echo in the exam. And what we see here, we see the mitral valve that is open. Okay, we see the atrial kick. Everything looks good. Posterior leaflet moving in the right direction. And now we move towards systole. Systole is where it starts, where the mitral valve closes here, right? And what you have, usually during systole, the mitral valve is closed. We just see a line. But what we see here is that when we come to mid-systole, when the echo is, we have backward sagging of the closure line that is diagnostic of mitral valve prolapse. So here is one. You can see it very well. You can see it even better here. Actually, both leaflets here are sagging backward to show you the characteristic pattern of mitral valve prolapse. And another condition that you have to know is that of hypertrophic obstructive cardiomyopathy. So first of all, on M mode, we can see the asymmetrical septal hypertrophy. We can see the septum that is thick, and you compare it to the posterior wall. The posterior wall in this patient is thin, and so we have asymmetrical septal hypertrophy, and beautifully demonstrated on M-mode echocardiogram. Besides that, we can see the mitral valve moving normally in diastole. Okay, so this is the anterior mitral leaflet, again the atrial kick and closing of the mitral valve here. The posterior leaflet also moves normally with closing here, so the MW is shaped. But look what happens in systole. In systole, you see the systolic anterior motion of the anterior mitral leaflet as it is approaching the septum, and you see really the outflow obstruction. The outflow indeed is between the anterior mitral leaflet and the septum, and here you see the systolic anterior motion and the anterior mitral leaflet. And you also may want to look in this patient, this is the same patient, you can look at the patient aortic valve. And you remember that on M-mode echocardiography, you see the diastolic line that just showed the closure of the valve. And when systole comes, the valve moving toward the opening position. And in the opening position, usually it looks like a parallelogram or like a square, but here it looks different. It opens early in systole, and then it suddenly moves backward toward the closure position. Why it's moving backward? Because there is systolic anterior motion. And with systolic anterior motion, there is less blood flow across the valve, and therefore the valve is moving toward this closure position and have the characteristic appearance. Right? And this is characteristic appearance with mid-systolic closure. And then if you look here, this is also long duration of ejection time. Usually the ejection time is about 300 milliseconds. Here it's about 420, 430 milliseconds. And this is characteristically, you see it when you have a big gradient across the valve. Actually, you can listen also with the stethoscope, and you see paradoxical splitting of the second heart sound because the aorta is closing much late. So this is a characteristic pattern that you should realize. We have some characteristic pattern. I think Dr. Urgema is going to talk more about it, and I'm not going to talk a lot about it, but just to tell you that you can see from the motion of the mitral valve, you can see all kinds of patterns that are characteristic of left ventricular dysfunction. This includes a longer interval between the tip of the anterior mitral leaflet and the septum. It's called etooseptal separation. And this was the first finding on echocardiography that was associated with prognosis. The bigger is this interval, the worse is the prognosis of the patient. This is because simply the patient has a dilated ventricle. You also see that characteristic closure that during the closure has an extra wave. We call it the B bump or the AC shoulder between the A and the C. We saw this characteristic shoulder, and this you see in patients with elevated left ventricular diastolic pressure. And sometimes you can explain things that are difficult to explain otherwise. For example, what is the M mode showing here? Does it show mitral stenosis, aortic insufficiency, a flail mitral valve, or a myxoma? Just pay attention. That's the anterior mitral leaflet, posterior mitral leaflet. All right, can we just vote for that? All right, let's see if we can. All right, it shows the answer, so I'm sure that you all were correct. So what we have here a flail mitral leaflet. Why do I say that it's flail? Because you can see that when you have a flail leaflet, the posterior leaflet starts its motion anteriorly, and only when it reaches anteriorly it moves backward, and therefore, if we go to the one before, right, if we go to this, you can see this is the anterior mitral leaflet, and this is the posterior mitral leaflet that first have anterior motion and then move backward toward the closer position. Okay, the mitral valve first moves, the posterior leaflet moves anteriorly, and then it continues to open and moves posteriorly. And then you can see really the size of the chambers. And you can see, for example, in this patient, the markedly dilated right ventricle. Always look at the pattern of the wall motion. You see that the posterior wall moves normally, but the anterior wall has a paradoxical motion. The anterior wall normally has to move toward the posterior wall, but here it move in the other direction. Also, you see that the right ventricle is markedly dilated, bigger than the posterior wall, and this is characteristic of right ventricular volume overload. You can see patterns like this with tricuspid regurgitation with pulmonic regurgitation, with atrial septal defect, and with abnormal pulmonary venous return. And sometimes, if you look very carefully at the wall motion, you can make things that probably will save the health system some money. For example, what you can see by simple M-mode echocardiography is that the two walls are not synchronized. While this wall is moving anteriorly, that wall was supposed to move backward, but you see that the backward motion took much longer, and there is a big distance between the peak motion of the posterior wall and the peak motion of the anterior wall, and this is really the demonstration of desynchronization. So this is poor man desynchronization, but let me tell you, it works as good as everything that you do with tissue Doppler and with whatever you are using. This M mode is not associated with increased risk of which one of those. And just for the sake of time, let's just go on the pictures and try to understand. First of all, we see that the aortic root appears dilated. Just eyeballing it, it is bigger than the left atrium that is behind, right? So we have a dilated aortic root. And as we can see here, this is the opening, the classical opening of an aortic valve. It opens, as I said, like a square or like a parallelogram, right? And this is the closure of the valve. And you see that the closure line of the valve is not in the center of the aorta. It shifted toward one of the aortic wall. This is what you see in patients that have bicuspid valve. So this is the classical appearance of M mode of a bicuspid valve with aortic root dilatation. Now, as you will find in your test, very frequently, you can make the diagnosis, but that's not what they ask you. They ask you, this M mode finding is not associated with increased risk of. So apparently this patient has a bicuspid aortic valve, and bicuspid aortic valve is associated with coarctation and is associated with subaortic stenosis, like in the Schoen syndrome, and is associated with aortic insufficiency. So the correct answer is B, pulmonic stenosis, that is not associated with a bicuspid aortic valve. This is an echo of a patient with endocarditis and shock. Again, I'm not asking you to make the diagnosis. I would ask you what is the best treatment of this patient. So patient has endocarditis and shock. Well, I'm looking for several things. And always look for the electrocardiogram. This is helpful. This tells you what is systole and what is diastole. This patient even has phonocardiogram. This is another technology that we don't use anymore unless you use your ears, if you wish, right? But this patient has a diastolic murmur, right? But now let's look at the mitral valve. This is the septum, this is the mitral valve, and you see that the mitral valve opens and the mitral valve closes here. Here? That's not where the mitral valve is supposed to close. The mitral valve is supposed to close at end diastole. When you have the QRS, this mitral valve opens long before the QRS. So we have premature closure of the mitral valve. And not only we have premature closure of the mitral valve, but we will see at this area, remember, this area is the left ventricular outflow tract between the septum and the anterior mitral leaflet. And we see this mobile mass that appears in the outflow tract in diastole. So this must be some kind either of a flail leaflet or even of a vegetation. This patient has endocarditis, he has shock. This is a vegetation, maybe with flail leaflet, flail cusp of the aortic valve that gives you this pattern. The best diagnosis, the best treatment, of course, is not aortic valve replacement. This is contraindication in severe acute aortic insufficiency, right? And it's not intra-aortic balloon pump. I'm sorry, I repeat that. This patient has no problem with the mitral valve, so he doesn't need mitral valve replacement. This patient does not need intra-aortic balloon pump. In fact, intra-aortic balloon pump is contraindicated in a patient with acute severe aortic insufficiency. And the answer is therefore aortic valve replacement. So again, note premature closure of the mitral valve here. Okay? And that echogenic mass in the left ventricular outflow tract, this is aorta or vegetation on flail aortic cusps. Remember that there is differential diagnosis of premature mitral valve closure. It occurs in severe acute aortic regurgitation, but it occurs also in first degree AV block. It can occur in high degree AV block. You can have it in blocked APC, and you can have it in atrial flutter. The reason is that if you have atrial kick during diastole to a ventricle that is not really compliant, what happens is that the pressure in the left ventricle increases above the atrial pressure. Why above the atrial pressure? Because in the meantime the atrium relaxes, and therefore the pressure in the ventricle after premature beat is now higher in the ventricle than in the atrium, and this causes premature closure of the valve. So you can see all kind of differential diagnosis. It's not necessarily an aortic regurgitation. Remember that. Look always at the EKG, trying to make also electrocardiographic diagnosis. And this is another patient. And we are looking at this patient, and this is very strange. This is the aorta. Remember, the aorta is usually two parallel lines that you can tell very simply, and behind the aorta is the left atrium. But I am looking at the QRS. Something is very wrong. You see that the aortic valve opens here. So the aortic valve opens long before the QRS. So we have premature opening of the aortic valve. So before we had premature closure of the mitral valve. Now we have premature opening of the aortic valve, which is a marker of very severe aortic regurgitation. From all these answers for the question, the most likely physical finding in this patient is, right? So, it has nothing to do with left subclavian pulse. It does have high pulse pressure, like severe aortic insufficiency. Doesn't have loud forced heart sound. This doesn't happen with severe aortic insufficiency. And it doesn't have apical systolic thrill. So why do we have premature opening of the aortic valve in patients who have severe aortic insufficiency? This diagram will explain it. Let's look at what appears here at yellow. This is the ventricular pressure. And if you have aortic insufficiency, severe aortic insufficiency, the left in diastole, the left ventricular pressure rises fast, and it rises above left atrial pressure, and at this particular point we have premature mitral valve closure. But there is another thing that also happened. If you look here, this is the aortic pressure. And if the aortic pressure in aortic insufficiency falls very fast, then toward late diastole, the pressure in the ventricle goes above aortic pressure. And this opened the aortic valve prematurely. M-mode can show you this very, very well, probably better than any other technique. Now I want us to vote because something doesn't work well with the slide, but let's try. A patient with this finding will have most likely which murmur? Okay? So the possibility is apical holosystolic murmur, apical diastolic rumble, low pitch mid-diastolic murmur at the right base, and diastolic ejection increased with the Valsalva maneuver at the left ventricular, at the left sternal border. So look at the picture and try to tell me what murmur this patient is have. So who thinks that the patient will have apical holosystolic murmur? All right. Who thinks that the patient will have apical diastolic rumble? Apical diastolic rumble. If you want to vote, raise your hand above your ear, because otherwise we don't know how to count it. Right, okay. Okay, so let's go back for a second. Oh, it works. Okay. So indeed, what we see here is a patient that has, go backward, 2 pictures. Go one more. Forward. Okay. All right, so what we see here is this. You see the fine fluttering of the anterior mitral leaflet. So the fine fluttering of the anterior mitral leaflet is what you have when you have aortic insufficiency and you have a jet, the insufficiency jet, that hits the anterior mitral leaflet. And with this jet, you have the diastolic rumble that is called the Austin-Flint murmur. And this is what a patient like this really has, okay? And the patient doesn't have low pitch mid-diastolic at the right base, because I don't know what condition give you low pitch mid-diastolic at the right base. So, okay, so the patient will have apical diastolic rumble. So while fine mitral valve flutter is indeed a marker of AI, mid-diastolic low pitch murmur at the base is not. Okay. Remember that fine fluttering of the anterior mitral leaflet is commonly seen with aortic regurgitation, but it is not a marker of severity. So the fact that it's there doesn't say that aortic regurgitation is severe. I'll show you now this as a last slide because I want also Dr. Origema to have a chance to do something here. And this for me is an important findings. Here is a 37-year-old woman with dyspnea and systolic murmur. What is the diagnosis? Again, I don't want to take you through the torture of this, but let me just show you what the patient has. This patient has severe pulmonary hypertension. The correct answer is B. Why? What you see here is all the component of the motion of a pulmonic valve in a patient who has severe pulmonary hypertension. Pay attention to the fact that the patient is in normal sinus rhythm. But you look here and you see a line that is very straight, and you don't see any motion of the closure line of the pulmonic valve during atrial contraction. This you see only when the pressure is elevated. And then when the valve is open, you have this unusual characteristic motion that is called flying W. So when you have a combination of no atrial kick and a flying W, this is a marker of severe pulmonic insufficiency, usually a mean pressure of 50 or more. So this is something that is very important, because we usually look at the tricuspid regurgitation and we measure the velocity of tricuspid regurgitation to try to reach ventricular systolic pressure. But sometimes we have no mitral regurgitation. Look at the M mode. Sometimes the M mode will tell you what is the diagnosis. So indeed, the patient has pulmonary hypertension, absence of ADIP in spite of normal sinus rhythm, and the flying W pattern. And this is really the opposite. This is a normal pulmonic valve on M mode. And what you see here, first of all, you see the atrial kick, and you see that the valve is open, but you don't have the flying W. What is the reason for that? The reason for that is that normally the atrial pressure and the ventricular diastolic pressure are very close to each other. And when the atrium contracts, the pulmonic valve is moving because the pressure are very close, one next to the other. On the other hand, if you have severe pulmonary hypertension, when the atrium contracts, this doesn't influence the motion of the pulmonic valve at all. And therefore, this is what you see in patients with severe pulmonary hypertension, and this is what you see normally. You see the atrial kick, and the valve doesn't have this characteristic motion. And you have to know also that if the patient has severe pulmonic stenosis, then during atrial contraction, actually the right atrial pressure and the right ventricular pressure rising above the pulmonic pressure, and therefore the pulmonary artery pressure, the pulmonic valve has a much bigger than normal atrial contraction. As a matter of fact, this is premature opening of the pulmonic valve that you see here, and this is characteristic for patients with significant pulmonic insufficiency, a very big opening wave like you see here. Okay, at end the diastole. So with this, I think that you have many more. This is what you see, for example, in pulmonary, in a patient that has pericardial effusion, but I think that you want to hear Dr. Origema as well, and I will stop here. Thank you.
Okay. Well, that's obviously a tough act to follow. To paraphrase a movie, My Cousin Vinny, everything this guy just said was brilliant. So actually, a lot of what I will be saying will kind of reinforce the points that Dr. Kronzen made. So I know the hour is getting late, so we'll go through this a little bit on the quick side. But first, I want to thank Marty and Steve Lester for their stewardship of this board review course. And they've done a magnificent job freshening things up, inviting new faculty, and making it dynamic. I think at the end of the sessions here, you will not only be a much better echocardiographer, you will be a much better clinical cardiologist because virtually every aspect of cardiology will be covered. So let me move ahead. So again, a lot of what I'll be saying is reiterates what Dr. Kronzen told you, and you have to go back a few decades to get good M-mode diagrams out of textbooks. And so this I got from an older edition of Feigenbaum's Echocardiography, which shows you essentially what echo was back when I was beginning my career in cardiology and as a medical resident. This is what echo was. You got 4 strips that represented the sweep of the M-mode cursor through various aspects of the left ventricle. And I'm going to just go through each one of these. But first I want to show you why we don't do M-mode, or we don't rely on M-mode echocardiography. Here's a nice M-mode through the base of the left ventricle showing you contraction. This slide is not in your handout. I just made it up a couple days ago. You see the M-mode cursor through the left ventricle, and you see at the base of the heart, you see nice symmetrical thickening of the walls. Unfortunately, this is a person where there is a distal left ventricular, distal septal and apical wall motion abnormality that the M-mode misses. So we do sacrifice spatial resolution, but what we get, as Dr. Kronzen said, in return is superb temporal resolution, and that's kind of some of the points I'd like to make as we go on. So what I've done here is I've given you a corresponding so-called anatomical M-mode that corresponds to the different positions of the M-mode cursor. Here we've got the M-mode cursor going through the main body of the left ventricle. Excuse me here, let me just move back up. Here the M-mode cursor has moved up a bit, and we're starting to catch chordal structures of the left ventricle. With this position here, we've got the M-mode through the mitral valve, and Dr. Kronzen elegantly described to you the various motions of the mitral valve. We'll reiterate that in a second. And finally, as we swing the M-mode cursor up through the base, we go through the aortic valve. So I'm just going to go through each one of these things. What we see when we have the M-mode cursor. Sure. This one here? Arsenio, you mean this? This one? Okay. That's easy. So here we have the M-mode cursor through the left ventricle. And a couple of things I'd like to point out is you have a nice uniform thickening of the septum. It's about 40%. And of the posterior wall. And as Dr. Kronzen mentioned earlier, M-mode still remains a good way of diagnosing dyssynchrony because in the normal individual, the peak downward peaking of the left ventricle, of the septum, and the peak upward motion of the posterior wall basically occur at the same time. When you have left bundle branch block, that nice symmetric synchronous contraction of both of those walls is disordered, as I have an example of that coming up. Here's, again, a blow-up of the M-mode cursor now through the mitral valve. And I think in the interest of time, I won't reiterate what Dr. Kronzen showed you about the motion of the mitral valve. Again, we have nomenclature for this, the A, the C, and pay attention to this region here, because this is late diastolic motion of the anterior leaflet of the mitral valve, and you'll see in one of the case examples a little bit later a disturbance in that, which we can use to tell us whether or not diastolic pressures and diastolic pressures of the left ventricle are elevated. Here's a nice example of the parallelogram that is aortic valve motion that one sees. Generally, we're imaging the right coronary cusp here, and that's this or this. And the non-coronary cusp is the more posterior that we're imaging here. And again, Dr. Kronzen showed you an example, and this would be prime board-type material, is they'll show you a case like he showed you where there is asymmetric closure. You see how this closure line in diastole is pretty much in the middle of the aorta. If you see this closure line in a very asymmetric position, that is a clue that you're dealing with a bicuspid aortic valve. In addition, one might see a dilated aortic root, which would be characteristic of bicuspid valves as well. So, you've seen this before in your pretest, so let's see if we can answer this. 49-year-old woman is in cardiogenic shock. What is the most likely diagnosis? And the choices are left bundle branch block, severe mitral regurgitation, severe aortic regurgitation, none of the above. Now, pay attention of the M-mode where this is located. You know, we do have the two-dimensional guiding of the M-mode echocardiogram, which does help you with the spatial orientation. So, again, use all the information that you have at your disposal, and please answer. Do we have some kind of M-mode type music? Okay, so the majority of the crowd went for severe aortic regurgitation. The correct answer is actually none of the above. Number 4. So this is a representative three-dimensional image drawn at random from our files. That is to say, one of the nicest 3Ds we've done in the last few years. And it shows, I think, in beautiful detail. We actually Kronzenized this 3D just for this. Dr. Kronzen was at our institution and gave us some very important tips on how to optimize a 3D rendering. You see, actually, in beautiful detail, the systolic anterior motion of the mitral valve and septal mitral contact in a patient with hypertrophic obstructive cardiomyopathy. So that's what this is actually showing. This is the biplane two-dimensional echo image taken from the same patient, just to prove to you that there is septal mitral contact. And this was actually a person who showed up with a stress cardiomyopathy and was in shock because of severe left ventricular outflow tract obstruction and severe mitral regurgitation. And here is the two-dimensional echo. You will be inundated with data at this course on hypertrophic obstructive cardiomyopathy. This will be covered in much detail, but suffice to say that it's sort of a twin double whammy. You have obstruction to outflow, and because the anterior leaflet of the mitral valve is pulled into apposition with the septum, you have mitral incompetence, and you have this cycle of eject, obstruct, and leak in that order. So this is a person who had hypertrophic obstructive cardiomyopathy, and on the two-dimensional echo through the aortic valve, you see the aortic valve opening and closing, but the M-mode shows you the improvement in temporal resolution compared with the two-dimensional echo. You actually, I don't think one can really appreciate the mid-systolic closure of this aortic valve from the two-dimensional image, but from the M-mode, especially on the first beat here, you see clear-cut closure of the aortic valve, and then a second opening as the pressure in the ventricle rises and overcomes the obstruction. Yitzhak, do you want to say anything about this?
Yeah. I think that one of the things that misled some of you is looking at that and not know what you are looking, what exactly you are looking at. Is it a signal of aortic valve or of a mitral valve? And just by looking at the motion of the aorta, you can tell where you are, right? So you can see that this is indeed the aortic valve, and therefore you can see the mid-systolic closure. And you don't have an EKG there, but this is just not to make it so easy.
Yeah, good point. Okay. This, I think, should be strangely familiar to you also from the pretest examination. And Dr. Kronzen covered this in detail, so I'm not going to go for the audience response on this one. But the most likely diagnosis here is severe aortic regurgitation. And I did, just to help you out a bit, I did put in a vertical line right at the QRS so that you see how prematurely the mitral valve closes. It closes, could I get an arrow somehow? The mouse doesn't seem to have an arrow. Anyway, the vertical line, here we go, thank you, times out with the QRS complex, and you see that there is premature closure. Again, from the normal M-mode envelopes of the mitral valve, you see that the aortic valve should be, that the second wave of mitral valve opening and closing should terminate right there, but you have nothing in here indicating that the mitral valve has closed quite prematurely, quite before the R wave. Now, I think what may fool, I showed this to our fellows, and I think some of the fellows were kind of fooled by this structure back here, which is actually just part of the mitral apparatus and posterior left ventricular wall. But this shows that there is clear-cut early closure in a patient, as I'll show you, who has severe aortic regurgitation from multiple vegetations and complete destruction by staph aureus of the aortic valve. So early closure of the mitral valve, as Dr. Kronzen has taught me over the years, to protect the pulmonary circuit from extremely high left atrial pressures. Comments?
Probably want to do the questions. Itzhak has some questions from the
Oh, okay.
Go ahead. We're running out of time.
So we have few questions. So this one is for you, I think, or Gemma. So maybe you want to answer it first.
What degree of mitral regurgitation allowed for accurate diastology? So I can talk about this on Tuesday when I give the diastolic talk, but it really, I think the better way of asking the question is, what is the etiology of the mitral regurgitation? Because study from Bill Little's group has shown that if you have primary organic mitral regurgitation due to, let's say, a flail leaflet, but no left ventricular disease, generally the diastology does not allow you to predict left atrial pressure, probably because of the big volume load. On the other hand, if you have a patient who has secondary or functional mitral regurgitation, generally the usual diastolic measures do allow you to predict filling pressures in such a patient. So that's how I would answer that. I don't think it's as much the degree of mitral regurgitation as what is the etiology. Generally, the diastolic function assessment will work if you have heart disease. It doesn't work as well if it's, say, a flail leaflet, but no underlying myocardial disease. Okay. What is the percentage of patients with epicardial fat? Why anterior to the right ventricle and not elsewhere? Increased incidence parallel to obesity epidemic. So, yeah, I'm not sure we cover fat in this course, but there's no question that you see the fat the best actually in this view here. And the people who have studied epicardial fat look at it right here to make their measurements, actually a little bit closer to the outflow tract. But so it turns out that fat that is located below the visceral pericardium does track with visceral fat elsewhere in the body and the metabolic syndrome. And in my personal observation, it seems that as we're imaging older and older patients, that degree of fat does seem to be increasing, even in people who don't have a lot of abdominal obesity or fat elsewhere.
Yeah, I mean, it's independently associated with diabetes.
So it's really a marker of atherosclerosis and also of shorter life. So this is a poor prognostic marker, as a matter of fact, and by itself this may be something that you would consider treating. Okay, I have two questions. The first question was, does premature aortic valve closure occur in acute or chronic conditions? So acute premature aortic valve closure, this is something that you see with severe mitral regurgitation. When you have severe mitral regurgitation, the ventricle empties prematurely, and therefore you have premature closure. If you listen to patients like this, they have wide splitting of the second heart sound, but this is wide because the aortic component moves earlier. So this is a marker of severe mitral regurgitation. So if you want to look at it in M mode, you definitely can do that. And now I have another question, and it says, you want to read it? The handwriting is a little difficult.
I'm going to whip out my glasses now. Okay, and then we'll get you guys to break.
Oh, take glasses.
Oh, okay. I know, this is faded. Okay. They're asking about,
Okay.
what is the number of beats to determine intracardiac versus extracardiac shunt?
Okay. That's a tough question, but you know, a better response for tough question is say, I happen to have a slide. All right? Can you just send me the slide? We just put the M mode on the slide. So hold it. Okay. So M mode contrast echo, this is something that is not used anymore, but it's a very elegant technology. What we used to do, we are injecting contrast, bubbles. Inject it into the vein, and then, this is working? Yeah. Up, go backward. Yeah. No, this is just moving the slide. Go backward. Okay. So, in order to see better, to point an arrow, what do I have to do?
The mouse.
This mouse?
Yep, there you go.
Okay, exactly. Okay, so we inject into the vein, and we see that the bubble appear, we see them very nicely, how they appear in the right heart, and look what happened. Exactly at the same time, within a bit, they appear also in the left heart. No interval between appearance in the right and appearance in the left. This is because the patient has a shunt, and when you have a shunt, once you have it in one side of the heart, blood goes within half a bit into the other chamber from right to left, and you can see and diagnose right to left shunt. Not only you can diagnose right to left shunt, but if you look here at the mitral valve, this is the mitral valve, there is still no bubbles, and then there are bubbles that appears first of all through the mitral valve, which means that this patient has a shunt at the atrial level. blood is moving from the right atrium to the left atrium, and then they appear in the left ventricle through the mitral valve, and you have opacification of the mitral valve, okay, or the mitral cavity. On the other hand, if the patient has ventricular septal defect, you see the contrast appear in the right side, and then within half a bit on the left side, but look how it appears on the left side. It appears not through the mitral valve, so it must appear through a ventricular septal defect, so I can diagnose ventricular septal defect with right to left shunt just by looking at that. And now the question was about what happened if I have right to left shunt extracardiac, for example, as you see with pulmonary arteriovenous fistula and so on. Well, what happens here is very interesting. First of all, I have the contrast appearing in the right side. And then look, 1, 2, 3, 4 beats. At 4 beats, I start to see bubbles coming through the mitral valve, and then they fill the left ventricle, and then they fill the left ventricle. So I can tell you that this patient has an AV fistula with right to left shunt just by looking at the M mode. Now, this is a fantastic information, but don't do it. Because what happens is that the actual recommendation is not to inject contrast if you know about right to left shunt. If you know about right to left shunt, you should not inject even bubbles. But this is, again, something that I don't think that it will be shown to you in the exam, but this is something to think about, another fantastic use of M-mode echocardiography.
Can you put on, Arsenio, can you put on projector 2? Switch me over to 2. So I just happen to have a nice example of the way the aortic valve behaves in somebody with acute severe mitral regurgitation. And you see, let's see if I can point this out with the mouse. You see how you don't have that nice parallelogram of the aortic valve. For some reason, this pointer is not working. But it almost looks triangular in shape. It was very, very different than somebody with mid-ventricular, mid-systolic closure. Oh, okay, thank you. With mid-systolic closure that you would see in hypertrophic obstructive cardiomyopathy.
And therefore, patients with very severe acute mitral regurgitation have a decrescendo murmur. Actually, you can see it here because there is less flow across the aortic valve, and therefore it moves toward the closure position. So this is the decrescendo murmur that you have with severe mitral regurgitation.
Okay, very good. Thank you very much.